So the next neurostimulation, the next workshop we are having is of Bigu ma'am, but unfortunately she is not doing well physically, and Dr. Arijit is just about to reach. He has already reached. So may I just request Dr. Arijit if you can just quickly show one more case in between before Dr. Arijit just comes in, so that we don't waste time. Maybe 5-7 minutes at least. It's a very interesting case of two paths but one disease. Two different mechanisms but one disease. Just a short picture.
So good evening, everyone. So this is the case that we faced in our stroke unit. The patient was of a 52-year-old female, postmenopausal, and with comorbidities of type 2 diabetes and hypothyroidism. She presented to us with complaint of acute onset pain on the right side of head and face for 15 days and diminution of vision in her right eye for 10 days. In the history of presenting illness, she complained of the pain in the right side of the head and face, and the pain was intermittent. It occurred in episodes of 3 to 4 episodes per day, each episode lasting for 7 to 8 minutes with spontaneous relief. The character of the pain was a bit unusual, that she said that it was intensely itchy type of pain, and it was severe in intensity with a VAS score of 9 out of 10 and triggered by touch associated with lacrimation, redness of eye and right eyelid drooping, as we can see in the picture adjacent to it. No, and not associated with any rhinorrhea, photophobia, nausea, vomiting or aura. Along with this, she had also diminution of vision in her right eye, which was acute onset, painful, associated with diminished color vision, but not associated with any distortion of images, flashing of light, eye redness or any discharge. The progression of the vision was relatively rapid over the 2 days and then static in course. In the general examination, it was not remarkable in finding in the general and physical systemic examination. In nervous system examination, while examining the cranial nerves, we found that the visual acuity in the right eye was finger counting at 1 meter, and in the left eye it was normal. The pupil there was right-sided RAPD, the left side was normal reactive. And in the fundoscopy, right side shows features of papillitis and the left side being normal. And while examining the rest of the cranial nerves, a positive finding of hyperalgesia in the right V1 to V3 distribution was found. The rest of the neurological examination was non-contributory. So to summarize the findings that we had a 52-year-old female who had diabetes and hypothyroidism, having features of optic neuritis, and with this possibly secondary trigeminal autonomic cephalalgia. This trigeminal autonomic cephalalgia, the duration regarding the duration and the frequency, it matches to the criteria of paroxysmal hemicrania. So, as in neurology, to localize, we probably thought optic neuritis and a probable trigeminal nerve involvement would localize the symptoms to an orbital apex with or without an extension to the cavernous sinus, and to jot down the causes of orbital apex syndrome, we needed to exclude the infectious causes, the inflammatory causes, the neoplastic causes, and the vascular causes. So in routine investigation, we proceeded. The routine counts were normal, the CBC, LFT, KFT, all the parameters were normal. We did in CSF, we found 7 cells, all of whom were lymphocytic, protein glucose was normal, the staining, culture sensitivity, CB-nat and malignant cytology were negative. Among the serology, VDRL, ACE level, ANA profile, and ANCA profile was also negative. We did a VAP, but it was unexpectedly normal. And we did proceed for the MRI brain and orbit. Here we expected to find a lesion in the orbital apex, but only thing that we found was hyperintensity and contrast enhancement in the right optic nerve, with no lesion or contrast enhancement in the orbital apex of cavernous sinus segment. So here's the missing piece. So there was basically two things: the right optic neuritis, as well as the autonomic cephalalgia. And to fit in the two, and we sent the demyelination profile that we routinely send, and NMO antibody came out to be positive. So optic neuritis is very common in NMO. So our final diagnosis, we had kept neuromyelitis optica with right optic neuritis and paroxysmal hemicrania. So to optic neuritis is very common in NMO, but the paroxysmal hemicrania, the TACs, we didn't usually hear these things in cases of NMO. So we did the literature search. We find rare case reports of trigeminal autonomic cephalalgia present in cases of neuromyelitis optica. So we knew that we are not alone. These cases has already been reported. We gave the patient high dose methylprednisolone, and for the paroxysmal hemicrania, we gave endomethacin trial. The high dose methylprednisolone was continued for 5 days, and after this, the patient started gradually improving in the tingling sensation. The pain that she complained of, there was improvement, mild improvement in this in her symptoms. However, the visual acuity did not improve. We tried to convince her to go for the further treatment, that is the IVIG and Plex, but unfortunately they were not ready for the treatment. So we discharged her on oral steroids and mycophenolate mofetil as a disease-modifying agent. So neuromyelitis optica is an autoimmune astrocytopathy with ecopyrin 4 antibody positivity. It commonly presents with optic neuritis, myelitis, ilia posterior syndrome. However, some cases of sensory trigeminal involvement and autonomic symptoms have also have been documented. So there are two pathways: the optic pathway and the trigeminal vascular pathway, which was being involved by this disease. So key take-home points from this case is that NMOSD can produce secondary TACs when the lesions involve the diencephalon brainstem, likely by disrupting the hypothalamic trigeminal autonomic circuits. And we should treat the attack biology and the inflammatory biology together. We should not delay the NMOSD care. Acute treatment, that is methylprednisolone, if not responding, Plex or IVIG, and we should introduce timely the relapse preventive therapy. Thank you.